The second speaker of our today's infection control audit is none other than Dr. Anusha Karunasagar. She is a very eminent personality. I know her for the past almost 15 years, and she is the specialty doctor in the Department of Microbiology. Now she is not in India, she is abroad, she is in UK, and at Princess Alexandra Hospital, Harlow, SW specialty, lead for microbiology, HWE laboratories as required. And she is an MBBS, MD microbiology, PhD, diploma in Royal College of Pathologists and CIC. And her awards, I think if I start reading, so many things are there, probably 19, 20 pages of her CV I saw today morning. And awards, just I will put a little bit of it. And awards and fellowships, she is received Pfizer Global Medical Grants to run advanced fellowship in infectious diseases. She's been awarded Society for Healthcare Epidemiology of American, that is SHIA, International Ambassador 2017, awarded short-term student for undergraduates research project of ICMR entitled Evaluation of Polymerase Chain Reaction for Screening Mentally Retarded Children and for Fragile X Syndrome in Mangalore. And she's also awarded ICMR Senior Research Fellowship 2008 to 2010 to carry out the research project entitled Development and Application of Polymerase Chain Reaction, PCR, and Restriction Fragment Length Polymerism, then polymorphism for the rapid diagnosis of neonatal septicemia. And she is an IAMM Endowment Award for the Best Outgoing Student in Microbiology in 2011 from Kasturba Medical College, Mangalore, Manipal University. Her research are projects and so many collaborations and book these things. She is a co-PI and part of code ICI and collaborations with colleagues, with colleges and universities for internship and projects. There are various publications and books also has been published, and she is a national and international figure. Without wasting much time, Dr. Anusha, over to you. Please enlighten us regarding the infection control, the audits, and also monitoring the implementation. Thank you very much.
At the outset, I thank Aho and in specific Dr. Ravikumar for being so kind to give me this opportunity to interact with all of you. So what we're planning after this really beautiful talk by Shri, my dear friend, I think it is important for me to explain a specific area because she has laid a great foundation for how audits are very, very important. Now, I'm specifically trying to look at a hemodialysis setup because that is one place where it's not an inpatient, nor it is an outpatient. You have a very susceptible group coming there, and there are so many people going in and out. You have a lot of organisms, and you have to keep in mind that this is a place where very sick patients may be there and will require probably ICU kind of support as well. So considering that, the sources for my talk today are, of course, the CDC and the Association for Professionals in Infection Control. But I've also taken excerpts from the KDIGO, the Kidney Disease Outcome Quality Initiative, and the Renal Best Practices. So if we look at patients in a particular dialysis unit, you have those with catheters, and then you have those with permanent AV fistulas and access points that are available. Now, both of these people have some things absolutely the same. One is, of course, hand hygiene, which is the primal basis for everything in infection control. Following that, you also have, of course, access. You have signs and symptoms of infection, which may be there because of the access. Whereas in a permanent AV fistula, maybe you can have some sort of infection that can come because of infection of the fistula, but not necessarily, from a routine kind of a fever. You will have people with catheters who develop and have problems outside the dialysis center. And the signs of symptoms are different when you are talking about a patient with permanent access. So all in all, I think we will go as per the agenda in terms of understanding this. So if we look at the modes of infection, it is important to understand that there is a puncture site. So there is a intervention that is going to be done. And there is an initiation and a termination of a session and a point where the blood circulates outside the body in a machine. There is a lot of interaction with a healthcare professional who has to set it up and has to terminate the session. There is an equipment that needs to be in perfect working condition. The water that is used with the filter is to be in perfect order. And you have patients who are immunocompromised, and therefore the environment which is perfectly. Now, many of us don't consider hospital dialysis units as important infection control areas because it is something that works like an outpatient department. Most of the time, there are 2 to 3 shifts in the maximum. And then you have one of the dialysis units that is probably kept in the ICU. But I think there is more to it than what actually meets the eye. When you're talking about 100% infection control as far as dialysis patients are concerned, let us see whose responsibility lies where. So if you look at the medical director of your institute, you call that a director, you call that a CEO, you call that all of that. There you have someone who leads a nephrologist, all of them, or anyone from the management who is entering the dialysis unit. You have to lead by example. If you don't do hand hygiene, you cannot tell your staff. And therefore, this is a team effort that you need to raise along with the nephrologist and your infection control team. You have to be aware of the different tools that are available and what are the recommendations in infection prevention and control. So if there is a new recommendation that comes in, it is important that there is correspondence between the microbiologist and the nephrologist so that the best care is given to the patient. You have to constantly review infection control practices and audits, and that is what we're going to focus on today. You have to address infection control quality initiatives through the month and practice hand hygiene. When it comes to the nursing side, because again, nurses are going to be the most common people who interact with the patient in a dialysis center. So again, they need to practice hand hygiene. They have to use aseptic techniques during or disconnecting the device, the equipment from the patient. You have to follow standard precautions. Scrub the hub is something that needs to be incorporated. Clean the vascular access site before any sort of infection. Allow the antiseptic to dry before inserting the cannula. Prepare and administer medications. There was one question which of course, probably in detail will be taken up. But pharmacy or compounding pharmacy, where you take one big vial of an antibiotic or any substance that is shared between individuals because you don't get the right volume. That is where it has to be absolutely careful, whether it is flushes, whether it is any of these things. If anything is being shared, that becomes a point of infection to other patients as well if contaminated. And therefore, it's always better, even if it's more expensive, to use single-use medicines. patients and family also have their own responsibility because they have to follow the care recommendations of the catheter site. They have to keep the vascular access area always clean. They should clean the vascular access area before coming into the hemodialysis center. In the hemodialysis center, of course, the nurses will do it, but they have to understand that if they have doubt, they need to speak up and practice hand hygiene. And finally, if you have equipments beyond the dialysis center, say in a separate area for in the ICU, all of the equipment are still the responsibility of the dialysis team. So is the water source wherever the machine is, and disinfection of the machine and the water that is supplied. So here, if you see infection control with dialysis setting alone, you have multiple areas and multiple people who are involved, and therefore it is important for us to understand that patients who undergo hemodialysis are at a higher risk of infection because there is an invasive device, they have a weakened immune system, and they are in and out of the hospital and in the community, so they are exposed to a lot more. If you see during the COVID period, everybody was asked to stay at home, but a dialysis patient couldn't stay at home. He had to come to a hospital at least twice or thrice a week to get his dialysis done because the kidney doesn't stop functioning, does it? So we need to understand that this is a very, very vital group of patients who don't really kind of support that we otherwise give those who are, say, in an ICU. For example, what is the water supply and how is that taken care of? There's really no one other than the infection control person who will look into this. So when you're looking at a basic concept of infection control, again, like was said earlier, it is important to understand what your local problems are and track the changes of time. Then you will be able to assess how effective your intervention is. So unless you have information that is collected, reviewed, and evaluated upon whenever necessary, it is important that we will never be able to understand the situation as a whole. So one of the key lessons, I will come to hand hygiene shortly, but before that, of course, is standard precautions. The dictum is every patient infectious until proven otherwise. And therefore, as an infection preventionist, your primary responsibility is patient safety, definitely, but also healthcare worker safety. And therefore, to tell your healthcare workers who are so passionate about their work, it is important to not name and shame them, that we don't make them feel that they're doing something, but to tell them that we need them to be safe. And if it is that they are not following a particular set of precautions that have been put in place for their safety, it is important to reinforce that. So perform hand hygiene, appropriate PPE, and safe infection control practices. This is definitely one of the important points that are needed. Now let's come to hand hygiene. All of us know the fundamentals of hand hygiene. I think everyone knows that we start singing happy birthday when we start washing hands, but then, it's very, very funny. Because when I came back, I wanted to, from my observership in infection control, especially in Basel, Switzerland, my professor there taught me that he had a system like this, a computer system, where he would get real-time data as there were of people using hand hygiene. He would know how much of hand hygiene liquid is used in each area. And therefore, he would know that in an area like, say, in the cancer unit or in the dialysis unit, the number of pumps need to be higher. So I said, okay, this is good use of technology. This was back in 2016. And so I said, this is good use of technology, but we can't afford it in a country like India. And he said, you don't need to afford it as that. Think of it from a local point of view. And my professor said, just go every morning, take a weighing scale and weigh how much of fluid has been used over the day in the past 24 hours. And that's your audit. And I thought, yeah, it's quite an interesting way to work. So I came back and I told my infection control nurse, and they were also very thrilled. They said, okay, just noting that down is going to be very easy. And so they then started the process in the first ICU. Day one, we saw that. Day two, there was little variation. Day three, I'm not seeing the results that I'm supposed to see. So I go there and I talk to the nurses. And then I say, listen, guys, you need to really improve this hand hygiene because I think we're using it very little. Considering an ICU, I think we need to increase the number of hand hygiene moments that are done. And funnily, they told me, they said, ma'am, but we're doing it. Every time you're here, we see what is, you see, we are doing it. And I said, yes, but it's the Hawthorne effect. When it is being observed, there is only then that we actually are getting the information. So I said, okay, how do I deal with this? Then they said, okay, how are you calculating? I said, no, we are now doing this new project. We are weighing the machines every day in the morning. Then there was one really smart nurse who picked up and said, ma'am, tell us what time you're coming every day. I said, why? How will that help? She said, we'll just pour out a little bit at least from every patient's hand hygiene, this thing, so that you will have the perfect result. So an audit is not to be done for the sake of doing an audit and for the sake of the result. And that stopped my project, as you can all see, that it was a futile effort. But what I learned from that is that I need for them to understand that this is really affecting their patients. And of course, we talk about having a patient in a dialysis center, and probably the nephrologists are the best as far as the hand hygiene moments are concerned, and in trying to push it for their from their staff. But if you look at one dialysis session, there are about 30 instances or opportunities for doing hand hygiene. But do you know, if you do it, and all of you can actually go back and do it in your units, you will see that a much lesser number of people actually are doing this. I don't think you will reach for about 30. The maximum you will reach is probably 15 to 16. So it's about, very clearly, about 50% of the number of times where there is an opportunity, but only 50% actually being effective. So it is important that we have dedicated personnel for training, for experience, and also who can allot time. It's good to have audits which are done, once a month or once in 2 weeks. And obviously, we are not having that much of manpower so that it is done more regularly. However, we need to try and form a liaison with the departments and then ask them to help us with the audit. Now, it should be done with the clearest perspective of saying that we want the hospital to get better. And so training of all facility staff members and implementation of evidence-based practices into the daily facility with standard precautions, additional measures needed that are designed to prevent transmission of bloodborne viruses, understanding facility-specific issues. All of this are able to, you can tailor and have facilities' unique circumstances. Now, the next thing is the environment. When you have a HD machine or a chair it is important that there is a 1.5 meter distance between the machine and the bed, and a 2 feet distance between each bed. Now, this is very hard because many a times people want to increase the number of beds, but this is where you need to draw that line and put your foot down. Now, if you look at the EPIC document, the Association of Physicians in Infection Control, they have very good standards for the different things that can be used in a dialysis unit. But that choice has to be from your end, because you need to know whether it is okay to use a quaternary ammonium compound. You have different generations of them coming up. Or do you want to use just hypochlorite? Or whenever you can't use hypochlorite, say for example, if you're using for the skin, you can't use hypochlorite when there is a catheter already placed there, because that will make the catheter material more brittle. So these are all practical important things that need to be done. And only when you go and talk to the clinical team and not sit in your high tower of a microbiology department will you be able to understand these practical difficulties and differences, and then find a middle ground. And so each of these things could be used as an audit tool. I will come to each of them. Now, this is a picture of our dialysis unit some time ago. But what you see is that each patient, you need to have a clean environment surface in the dialysis station. What we did was eliminate the use of um, anything that is shared between patients. So it was single use, and even we didn't even allow it to be reused for the same patient. So it was single use. The countertops have to be absolutely clean. External surfaces of the dialysis machine should not have blood stains from a previous dialysis. Nobody would want to get their dialysis done there. The containers where the prime waste is that needs to be kept properly and not just left open. It's usually in these white cans where you have, it left open. That is very corrosive, and that needs to be addressed. You can just use soap and water and detergent for most of the cleaning of a dialysis unit. Wherever the high-touch surfaces are there you use a germicidal detergent. The first step to any disinfection is to pre-clean. So it's not enough if you directly use an alcohol swab or alcohol wipe or peracetic acid wipe or peroxide wipe. Excuse me. But it is important that you remove anything, any organic material, because otherwise no disinfection is going to work. Now, when you clean the external surfaces, you can use an registered disinfectant, because we don't have something like an EPA here in India is yet to be developed that is strong enough to be able to give us quality guidelines. So you can use that. And the internal bioburden of the organism can be reduced if you clean it either with heated water or with certain chemicals that is to be decided with the company who has supplied your dialysis units. Now, the dialysis unit has a lot of blood, because any disinfection, you may have blood-stained, infections that are there outside. You may have a lot of blood-stained, dots or stains that are around, which need to be cleaned. And ideally, a hypochlorite solution is enough. But most of the time, what you need to emphasize is friction, the way it is cleaned. So the S kind of cleaning pattern, or a Z kind of cleaning pattern that the housekeeping needs to be followed. So every part needs to be cleaned. Items that are not that are taken into one dedicated use area, don't just pick it up and say, okay, the next patient needs this, can I just pick it up from here? That could be just simple as an adhesive tape or a cloth covered BP cuff. But all of this needs to be kept separately. The non-disposable items like scissors, etc., don't put them into pockets. We had one of my experiences, worst experience, I can say, one of the worst experiences at least, is when a young nurse kept, I think that was a scalpel blade, which she used to cut, to do quickly, be able to cut anything, in her pocket um, in her pocket on the coat, and that cut through the pocket and then caused a deep gash for her in the arm. And this was a big problem that we had, and we still failed her because that is important that she is not being affected because of our negligence in our. So it's constantly, we have to engage with every team. So medical equipment like scissors, all of these, you have to clean and apply a hospital disinfectant on them, which are visibly, when there is visible contamination of blood, you have to use an intermediate level of disinfection. Appropriate contact time is very, very important, whatever the disinfectant is. So how long can you use it? Not that you dilute and keep it in a bucket and that you can reuse it the next day. Okay, it doesn't look too dirty. The pH may change, so not to be allowed. Blood spills, as you know, has to be treated with tuberculocidal agent, as well as the best way to go ahead with household bleach. And staff members doing the cleaning should wear appropriate PPE. It's important that don't use a towel which is filled with blood to clean and then spread the blood all over the surface of that particular infection. It is important that there is a separate cloth that is used to clean blood and blood products. You have blood pump, dialyzers, you have all of these. Everything needs to be spick and span. Where you store it, how often you clean, which area, touch surfaces, how do you clean the top of the object first? Do you go a top-down approach? What is the kind of disinfectant? How often if you're using a cloth, how often do you replace it? Do you use the same cleaning cloth for more than one patient? Ideally, you should not. Can you dip it, like you wiped half the surface, can you re-dip it into that and use it out to reuse it again? Now, all of these are absolutely no. Even when you're microfiber cloths, it's important to understand that these have to be washed on a regular basis. So you wet mop the floor, clean the the bathroom areas, because patients are there for 3 to 4 hours, and so is their family waiting outside. So the bathrooms can get very dirty. Next is, of course, specific recommendations. Dedicate supplies to a single patient. Unused medications need to be discarded. You can't keep them. There is a temptation not to waste. I understand that, but it does not mean that we are doing justice. We might be spreading infection that way. How you carry medications. Don't allow the nurses to put it all in their pockets and be able to give it at a jiffy. Use a proper medication cart. And if a medication cart has gone into one area, it is important that you don't take it all around giving, distributing infection and the supplies, and also how you use each of these, and cleaning of the cart itself. Many a times the carts are never cleaned. They may be made of metal, but on that you will have the pad which is used for patients' underpad will be on top of this beautiful, nice steel trolley. The steel trolley is much easier to clean. This is absorbing any infection that is there. And that is how we spread infection from patient to patient. So cleaning and disinfection is very, very important, to use the right disinfectant in the right area and how you clean every area. Safe handling of all the tubings and the dialyzers. The hemodialyzers can be disinfected with peracetic acid, formaldehyde, glutaraldehyde, heat pasteurization with citric or chlorine-containing compounds. Hemodialysis systems usually are disinfected by chlorine-based disinfectants, and some of you have to go and talk to your equipment provider, because we have to understand what are the ones which are recommended by them. So when do we do, how do we do is important. So how do you prevent, of course, an irritated skin? Now the patient be directly getting an infection, but say a patient has um, shingles when he's come for dialysis, and that is spreading to the eye of the ophthalmic area, that could still possibly be a source of infection to other patients who are not in the best way. They are also immunocompromised, so they get exposed, and if they've not before, they can get chickenpox. As far as dialysis patients who are having diarrhea, again, something that we need to be very, very careful about, because they can be sources of not only the bug that is causing the diarrhea, but also they can be exposing so many others to multi-drug resistant organisms. Of course, respiratory infections, I think it's important that distances are maintained, patients wear a mask. Now, water treatment is something that all of us have a lot of trouble in India, because either there's too much of chlorine content, and that's not very good. So a good RO system needs to be there. Now, when we have a good RO system, you have to also do, as you know, the requirement is to do the RO testing for the water, the culture, and also doing testing for the lysate test, which is needed for endotoxin testing. So maximal level of bacteria in water should not exceed 200 CFU, and should not exceed, endotoxin should not exceed 2 EU per, that is endotoxin units per ml. So where are the sites that need to be tested? So one is, of course, at the point where the water leaves the RO before it enters the holding tank. If the RO holding tank is present, then sample should be taken from the source, because you don't know whether there is a problem in the distribution loop or in the, is your RO filter not working properly? So that is important. The dialyzer, once the water enters into the dialyzer reprocessing system, there again, we need to get the testing done. And then you have to look at when the water enters, the bicarbonate concentrate and the whole loop there again, and of course your LAL test for endotoxin. So if we look at again the total viable count here, as per the AMI dialysis standards, we will see that you need less than 100, where actionable level is 50. This is for dialysis water as well as standard dialysis fluid. For ultra pure dialysis fluid, it has to be less than 0.1. Toxin level has to be less than 0.03. And if it's an online prepared substitution fluid, then it has to be absolutely sterile and non-pyrogenic. Now, what do you do? So you collect the dialysis water, bring it to your lab, pass it through a filter, which is then the filter that is taken and then put on a tryptone glucose agar extract, which is to be incubated at 17 to 20 degrees for about 7 days. Or you could use a Reasoner's agar #2 plate. Now, staff members should not also eat or drink in a dialysis unit. Patients can be served meals, and like in the house of a patient, you don't need any special kind of disposable cutlery. But the housekeeping staff members also should promptly told about removing waste, infectious waste, blood, or any other spills that have occurred. Double bagging may be required in many cases, and the waste generated may be contaminated and therefore has to be properly discarded. There is no question of rediscarding. As far as, of course, the injection safety is concerned, like I told you, it's always important to use single dose medication vials. For flushes, you can use pre-filled syringes, which make it a little more simpler, and it reduces the chances of outbreaks that can happen. Store vials appropriately. Again, each of these key recommendations can be used as an audit tool. So first you put the practice in place, and then after that you use it as an audit tool. Training is very, very important. Of course, there is annual training that needs to be given to all dialysis employees, but it's important that training is given on various aspects then and there. Now, with dialysis, of course, many of our dialysis units has a separate machine for hepatitis B, separate for hepatitis C, and for HIV. I think the newer machines now, there is no requirement for this, but if it is already being done, I hadn't changed it in India. As far as the kind of access is required, the best would be to create a fistula. Of course, until then, we understand that grafts may be used and catheters are more prone to infection. So again, you have different recommendations can be used as audit tools for vascular access infection prevention measures. Now, respiratory pathogens are very important, especially to an immunocompromised group. And as you know, dialysis is never, where you have individual patient cubicles or rather rooms. Patients are generally in cubicles or in open spaces, and therefore they are more prone to infections. Or they will be traveling in public transport to come to the dialysis center, and therefore, again, it's very important that they are vaccinated annually for influenza. Staff who are sick should not be really coming to work, but all of us face staff shortages, and therefore it's important to preventatively, give them also the flu vaccine. The PPV23 for pneumococcus is also a very good option, and boosters need to be given as and when required. With MDRO, you can't really decolonize a patient. Multi-drug resistant organisms, hand hygiene, and standard precautions are all that is required. Again, there are different recommendations depending on the agency in terms of catheter-related infection. But again, it is important to stick with what you have done and audit it based on that. So when you look at the CDC recommendations, or if you look at any of these, they talk about surveillance and feedback, hand hygiene, vascular access, staff competences, and as well as education, patient education and engagement. Get the patients to talk to other patients. So they will tell them how practically what are the difficulties and how they can address it. Catheter reduction, chlorhexidine for skin preparation, catheter hub disinfection, and antimicrobial ointment on the catheter site. All of these become important. I'm not going to go into details of this. So to summarize, be aware that every session is a potential risk for the patient. Cleaning of the environment is a very, very important thing. Disinfection and cleaning of the dialysis machine fluid path is also something that we never think of but have. Hand hygiene becomes very, very important, especially during the start and the termination of the session, more so also in between. Injection safety, screening of patients, immunization of patients as well as healthcare personnel, separation of known cases of infection into cubicles is important, and education and transfer of knowledge and efficient surveillance and audits. This will help you keep your dialysis unit in perfect condition. I hope I have been able to do justice, because it's very important that we as microbiologists take responsibilities and give special importance to areas such as these. Thank you again to Kaho. Happy birthday, and thank you for the opportunity to interact with you all.
Thank you, Dr. Anusha, for a wonderful and fantastic lucid presentation.